I'd like to introduce our next speaker. Dr. Peterson will get him mic'd up here and his presentation ready. So give us please a couple of minutes. Okay. Dr. Peterson brings over 50 years of experience as his role of professor of medicine, UCSD. He served as a cardiology consultant both at the Naval Regional Medical Center and the Veterans Hospital in San Diego. Today, his talk will be about heart attacks in women versus men, a comprehensive exploration of cardiovascular health. Let's give it up for Dr. Peterson.
Well, thank you very much for inviting me here today to this gathering, and I must say that this is a very stimulating subject for me after 50 years, as I said, in the field of cardiovascular medicine. I'll try to highlight for you the fact that it's really only been in the last decade or more that this has become a major issue in cardiovascular disease. And I hope I highlight some of the champions of bringing this to the fore. I can also tell you that sitting here, I enjoyed very much the previous speaker's presentation because I thought she was very current and also very up to date in terms of what I read today about the role of sex differences in cardiovascular disease. Now, I've been asked to hone down now though, on the differences of sex and gender care in the entity of acute myocardial infarction. And to make certain that you understand an acute myocardial infarction is probably the best counterpart in medical parlance to what we now usually call a heart attack. A heart attack sometimes in just community parlance may also be related to an arrhythmia of the heart or a passing out spell or something like that. But I think when we normally refer to a heart attack, even in community parlance, we're referring to the entity of myocardial infarction. So what is a myocardial infarction? It's the end result of myocardial ischemia, myocardial referring to a heart muscle, and ischemia is a medical term that maybe all of you might not be familiar with, which refers to an imbalance between heart muscle oxygen supply and demand. And the most common cause of that is a reduction of the supply related to a reduction in coronary blood flow. However, it can be brought about by other mechanisms as well, so that an imbalance occurs, and there are instances where myocardial infarctions can occur, even though coronary blood flow appears to remain relatively normal. Now, the other point I want to make is that when we refer to men and women today in almost all the studies of the last 40 to 50 years, we're referring to their biologic sex determined at birth by phenotype. Phenotype being the observable characteristics of that individual at the time of birth. Let's see, is this working or not? Beyond. What worked out? All right, good. All right, so I've taken this cartoon out of Brownwald's heart disease. Eugene Brownwald, you might be interested, was the first chair of medicine at University of California at San Diego in 1968. I came here in 1970 to work with his group. And Dr. Brownwald is one of the best known cardiologists in the world. He developed a textbook which has now sold more than almost any book in the medical literature. And it's a wonderful compendium for those that are not aware of it, of cardiovascular disease. In any case, this cartoon shows the various causes of a myocardial infarction that are most commonly encountered. And right at the top is where you have a plaque that ruptures or is eroded. And on top of that plaque develops a thrombus. And that occurs in approximately 67 to 70% of patients that develop an acute myocardial infarction. And it's the target that today we try to reverse by various procedures that you will hear about later. It could also, however, be brought about that coronary obstruction in this area that's giving rise to the loss of blood supply downstream from that due to vasospasm, or also due to a condition known as endothelial dysfunction, and that's where the extra tone of the vessel is brought about by various disease processes. Now, occasionally, as I mentioned at the very beginning, you can have fixed atherosclerosis, the supply-demand imbalance. You don't have a dynamic change in the coronary diameter. And also you can see a few instances where a supply-demand imbalance occurs alone. Now, one of the things that's helped us greatly in understanding the anatomy of what goes on in the coronary arteries during an acute myocardial infarction is a technique known as optical coherence tomography. And this particular slide shows some examples of that. Here on the left is shown a plaque rupture. You can see right here the rupture in the plaque where those two arrows are. And then there's a discontinuous fibrous cap on top of that. And then over to the right is evidence of a thrombus that is formed on that. You can also have, rather than just an actual rupture, erosion of the plaque with an irregular surface, which can also give rise to the mural thrombus forming on top of it. And then also occasionally we see instances where there is a calcified plaque and it forms a nodule upon which the thrombus attaches as well. And this also shows several less common sources of abnormalities, which I mentioned before, where you have a spontaneous dissection in the coronary artery. You can see here that a rupture has occurred in the wall where that arrow is. You can see that it literally forms a false lumen in the artery that actually can then begin to extend up and down the coronary artery. And you can also see in some instances, rather than a rupture, a dissection that happens actually spontaneously. You can't see the entrance to blood into that dissection plane. Also, oftentimes it fills with a thrombus, and as that happens, slowly occludes the orifice of the coronary artery. Now, I show you those two examples only because it has been seen, as it was noted by our previous speaker, that disease process can occur more frequently in women than it does in man. The most common way, however, that we detect whether there's a thrombus in the coronary artery is by doing coronary angiography. And if somebody asked me what was the most important diagnostic technique that was developed in the 20th century, I would probably tell you that I think coronary angiography is the correct answer, because it was this technique that really opened up all of our knowledge about the pathoanatomy of atherosclerosis in the coronary arteries, and also opened up the whole field of what we call today interventional cardiology, which deals with the consequences of a plaque and thrombus in the coronary artery. And this shows a picture from an article taken in the American Journal of Medicine that was published just a couple of years ago. It highlights the history of the difficulty in proving that thrombus was an important part of the whole pathogenesis of acute myocardial infarction. Now, one of the important things to realize about myocardial ischemia is that it's a very dynamic process. I mean, once the atheroma is there is one thing, and a lot of people, crazy. Apologize. All right, there we are. The atheromatous stenosis of the coronary arteries is just the initial process to reducing perfusion. But after that, in the using this, I can see that. It flips ahead. It doesn't go back like it should. I apologize again. There. All right, so I'll just have to point. As you can see in the third box down, you start to see the accumulation of metabolites that are abnormal in the heart muscle as the perfusion is reduced. And then over a period of time, you have the formation of reactive oxygen species. And all of these serve to depress the overall mechanical function of heart muscle. And initially, that depression is reversible. And it's been found both experimentally as well as clinically that if you can enter the coronary artery soon enough and can reverse that perfusion deficit, you can then lead to a recovery of a lot of those fibers. They remain stunned for quite a period of time, sometimes up to 24 hours. But after that, they slowly recover, and you can ultimately relieve a lot of the mechanical disadvantage that is brought about by an acute myocardial infarction. And you can see over here on the left or your right, that in addition to the thrombus and the vasospasm that could sometimes be shown with that, there also is an increased demand that's placed upon the heart, and part of the mechanical area of the heart is no longer functioning properly. For example, if you lose the anterior wall of your heart, it puts much greater stress, much more difficult work requirements on the inferior and apical portion of the heart, particularly the left ventricle. And ultimately, if it lasts long enough, you get irreversible injury. And then a person who is left with that irreversible injury ultimately is the individual who several years down the road has a state of refractory congestive heart failure. But we do know today that a lot of the effort that we put into trying to rescue function of the heart at the time of an acute myocardial infarction serves us very well down the road in terms of making certain that chronic congestive heart failure does not develop. I'm going to do this carefully now and see if I can. There. All right, now one other point to be made is that as that mechanical dysfunction of the area of ischemia first develops in the early stages of a heart attack, it's well known today that the earliest sign of dysfunction is on the inner portion of the wall of the left ventricle. And only with time does it go across the wall and become what we refer to as transmural. And it's that transmural dysfunction that ultimately leads to a lot of further downstream changes in the heart muscle that ultimately leads to congestive heart failure. That whole process is known as myocardial expansion. So One of the things we hope to do when we intervene on a patient with a myocardial infarction is to get there within a couple of hours, because we know that at that point, usually only subendocardial damage has begun. That is to say, only on this inner area of the heart muscle. And we are hoping to avoid the condition where the full thickness of the heart muscle has been damaged. Now, this shows graphically what happens as we go about trying to restore that flow. And ultimately, the game is to get there within 2 hours, as I pointed out on that previous slide. Notice, though, function there, which is shown as the blue curve here, is plotted here against the viability of the muscle. And you can see that if you did nothing at all up to 2 hours, why you would have a persistence of the severe dysfunction that started as early as 2 minutes. In other words, if 100% of the original function is shown here on the vertical axis, you can see here that by 2 hours, it's remained the same. And then if we intervene at that time, we can usually bring the state of function back up to about where that red line is. We can't bring it back usually to its full function that's shown there in the red on top. So the whole success of salvage of the function of the myocardium is less and less as you go out beyond 2 hours. Now, how do we make the diagnosis of an acute myocardial infarction? That's the other thing that I want to go over with you here. And one of the reasons this is important is it highlights part of our difficulty in treating men exactly the same as women. Symptoms of an acute myocardial infarction are actually quite variable in both men and women, but it turns out they're probably more variable in women than in men. And they may include chest, shoulder, back, stomach, neck, and even head pain. I've seen many, many patients who completely befuddled me based upon their history, turn out to have an acute myocardial infarction. So it's not an easy task to just go to the bedside of somebody who's come in with one of these complaints and immediately zero in on the fact that this is a myocardial infarction that's occurring. Or they may show up only with shortness of breath, or they may show up only with severe sweating. That's the term known as diaphoresis. They may be lightheaded. They may complain of feeling like they want to pass out. Or one of the more common things that I used to run into is profound weakness. So because the symptoms can be quite variable, you can see that self-recognition is a problem. It's also a problem for people who are around the individual who's experiencing the symptom. And getting that patient to the ER within 2 hours is obviously going to be delayed by the confusion that's created by the variability in those symptoms. So there's no easy answer to this except through public education and trying to make certain people know that there are many manifestations of an acute myocardial infarction. Once the patient comes to the ER, physical examination may help the physician. I'm not going to go over all the details there, but first and foremost, initially, we depend upon the electrocardiogram. And there are some very specific electrocardiographic findings that we look for immediately, and they aren't always there, unfortunately. If they are there, then it helps us enormously in putting the patient then on the treadmill, you might say, or the vector of going to the heart catheterization laboratory where the reperfusion will be instituted. Now, the other thing that's also used very early on in the emergency room are biomarkers, particularly troponin T and I, which are two proteins released by the heart muscle as it begins to break down in response to the ischemia and early infarction. And it will highlight later the fact that troponin T and I are also somewhat different in men and women. And in fact, the normal values for those two proteins on any given assay can be quite different in men and women. This shows now a slide that highlights just the electrocardiographic changes, and this is one ECG complex here on the left here, normal, and what we look for initially is what's known as an ST segment elevation. And that's where this part of the electrocardiogram is elevated above the baseline. And then over a period of time, what's known as a Q wave develops. And between those two, you usually have the definitive signs of the most severe transmural myocardial infarction. As I mentioned earlier, unfortunately, all these findings aren't always there, and it may take more time for them to fully develop. The other point to be made is that the ECG and the various leads of the ECG, as shown up here on the left, can reflect what area of the heart muscle has been damaged. And the so-called leads 2, 3, and AVF tell you what's going on the inferior wall of the heart. And the leads V1 through V6 across the anterior lateral chest wall tell us what's going on the anterior wall of the heart down to the apex. And then AVL, which is shown way up there on the top, is one that also is very useful for a very isolated infarct that occurs on the high lateral wall of the left ventricle. So you can, I think, get some idea just from this slide how important ECG is in being applied very early to the patient who's come into the emergency room. And one of the very specific criteria that we use is how high that particular ST segment has become. That's shown by 2 there. And we're looking in women for a difference of at least 1.5 millimeters compared to the baseline, and in men, 2 millimeters. So here's another example of where it's been shown that women are showing less of a change that comports or correlates with a significant infarction than does a man. Now, as shown here, many infarcts are not associated, however, with a criteria of a so-called ST elevation myocardial infarction, which is the one that usually shows that there's been transmural damage. But a lot of them are what are known as non-STEMIs. And so most of what we deal with today and send to the heart catheterization laboratory, though, are ST elevation myocardial infarction, because those are the more severe. Now, one other point I want to make is that there are many conditions that can lead to a significant ST segment deviation. For example, just an inflammation around the heart. So a good cardiologist has to be very alert to the fact that many other things can simulate a myocardial infarction even on the ECG. So again, highlighting the fact that between symptoms and the ambiguity on the ECG, you can run into a lot of difficulty in making this diagnosis with certainty. Now, I mentioned earlier that biomarkers, particularly troponin and troponin release, is very important today in making the diagnosis as well. And in this particular slide, the normal range of cardiac troponin is shown here in the green area with the 99th percentile. And what happens is, as troponin is released into the blood, usually by within about an hour to 90 minutes after the beginning of the ischemic process, leading to infarction, you can see that that troponin level starts to go up. And so usually when we draw the blood on the patient in order to try to detect this rise in troponin, we have to wait at least about 90 minutes before we can pick that up. If you arrived at the emergency room, say just 30 minutes after the beginning of the process, it might still be normal. So it might not help you at all. So again, you have to be careful in how you interpret that particular enzyme. It also is very, very important to recognize that you're looking for a change as well. So you do one enzyme as early as possible after arrival at the ER. Then what you do is to get another one within a half hour to an hour after that in order to see if there's been a marked change. Here are just a couple of important points about cardiac biomarkers, particularly troponin in women versus men. First of all, the assay technology has improved a lot, enhanced, and does reveal, as I mentioned earlier, important differences between women and men. Use of a uniform threshold does not provide equivalent prediction in women and men, with lower thresholds needed for women to provide comparable risk stratification. And then finally, women have lower cardiac troponin concentrations than man in general. And that probably reflects the fact that women's hearts are smaller and the infarcts are therefore smaller, and therefore you don't get as much of a release of the enzyme into the bloodstream as you do in men. So that's another point that has to be taken into account. Now, there are also some other biological reasons why there might be some sex differences in terms of cardiac troponin. Men also have a greater left ventricular mass in general. That is to say, even for the same weight of heart, oftentimes the mass is a little bit greater in a man than it is in a woman, so that when the infarct occurs, you get more of an enzyme or protein release into the blood. Age-adjusted blood pressure in men is a little bit greater. Sympathetic nervous activity is thought to be greater in men than in women. Also, there's some evidence that estrogen can induce an attenuation of ventricular hypertrophy or muscle mass in men as opposed to women. And so those can all contribute to differences in the release and clearance kinetics of these protein biomarkers that we use. All right, I'm going to, I've gone over a lot of this diagnostic interpretation of the troponin. So in the interest in time, I'm going to move on and point out that occasionally we get patients that we can't really be absolutely certain whether a myocardial infarction is occurring or not. And in that instance, we then turn to cardiac imaging right in the ER. And one of the most valuable today is two-dimensional echocardiography. And on this next slide, I'm just going to show you here the echocardiogram. And I purposely put this in here to show the fact that we can get an excellent echocardiogram that shows the function of the beating left ventricle. But also, the other thing I want to point out to you that this is a mouse, not a man. And it just shows you that if you can do this in a mouse, you can imagine how well you can do it in man. And the other thing I want to point out to you is that look up there at the apex, if I can make this, resist. All right. Now, see if I can make it beat again. There we go. If you look at the apex of the left ventricle here, you can see that the muscle is not contracting. It's contracting high up on the anterior wall and on the inferior wall. In other words, the anterior wall is up on the top part and the inferior wall is in the bottom part. But here to the left at the apex, it isn't moving at all. And then what I want to show you is I want to make this beat down here. So if you do nothing to the mouse between 2 weeks and 8 weeks after they develop a myocardial infarction, you'll see what happens to that area. Now, I think you can appreciate what's happened to the heart and how much worse what we call that wall motion abnormality is, the apex now, compared to what it was even at 2 weeks. And what I don't show on this slide is what a normal contraction is. A normal contraction is that whole apex would be moving and contracting just like the rest of the heart muscle is. So it's that regional territory of injury gets worse and worse over a period of time. And that's known as remodeling of the left ventricle. So one of the objectives that we have in treatment today of acute myocardial infarction, and one of the reasons we like to get there early, is to impede that whole process of remodeling of the area of the infarct. Now we can also look at whether there's an infarct in the myocardium today by using contrast magnetic resonance imaging of the heart. And gadolinium is a contrast agent that leaks into the extracellular space of the heart muscle when it's injured. It's shown diagrammatic here by that white area outside the central area of the chamber. And you can see this is what it looks like on the magnetic resonance scan. And you can also pick that up just along the endocardium. Subendocardial is what it's referred to there, and it can also be quite focal. Or you can see a very large territory of abnormality. So that can also be a very useful way in order to pick up a myocardial infarction. I'm going to move ahead quickly now to go over now one of the important things that I want to emphasize, and that is that yes, heart attacks are very important in females, but it also remains to be a very, very significant problem in males as well. If you look here at this data that was just published in 2023 by the American Heart Association, I think you can appreciate the fact that taking patients from the age of 20 to 39, 40 to 59, 60 to 79, and 80 plus, why the prevalence or the percentage population, the myocardial infarction just keeps going up and up. So that by the time you're beyond 80, you have about a 16.5% chance, if you're a male, that you're going to have a myocardial infarction that leads to your demise, although it can also happen. This is just prevalence data, so it's not necessarily your demise. It could also actually be just something that you recover from as well. And notice that even at about 80 plus, it's twice the prevalence of women. So it's a very, very important problem in men, and I don't want you to leave this seminar today thinking that we should stop paying attention to men as well. Obviously, I'm buying into the business of women, but I also want to make sure you recognize the fact that it's still a very highly prevalent problem in men. And one other point to be made is that if you include a new MI, that is to say now looking at incidence of the disease, rather than just the prevalence of it, is the development of a new MI based upon age, or a fatal coronary heart disease episode. And the reason they include that statistic is because oftentimes people die of an acute myocardial infarction. They die before you can find any evidence of it, an autopsy, or before there's any clinical evidence that it's been that it's developed. So it's a common cause, that is to say, of sudden death. So that's why it's included in these statistics. And you can see here that it takes going all the way out to beyond the age of 85, which is way over the right there, for women to have a higher incidence of MI and sudden death than men. These are statistics that are just released in just the last year by the American Heart Association. Now, I think I've already highlighted to you these important facets of optimal care, that time is muscle, and that muscle is horsepower. I think you can also appreciate that. It's that final bullet point there, though, that I want to now turn to, and that's that female sex has been correlated with delayed hospital attention and worsened treatment outcomes. And it's only been in the last year, or last decade, I should say, that we've really had a lot of attention paid to this. And the person who I attribute a lot of the credit for going ahead and educating a lot of us in the cardiovascular profession about the inadequacies of our study of women in coronary heart disease is a lady named Nanette Wenger, who was at the Emory Medical School. She gave a lecture at the Council on Clinical Cardiology that I heard in 2011, and then she published it in 2012. And it was that lecture at the American Heart Association that I think made us very, very much aware of how inadequate our attention had been to this sex difference in women up to that point. And it took then about 5 years for there to be a major report by the American Heart Association in 2016 that was entitled Acute Myocardial Infarction in Women, and which highlighted a lot of the deficiencies. And one of the things I want to point out to you is that this should have been evident to us much earlier in our studies of acute myocardial infarction. This slide right here shows the risk of mortality in women compared to men in randomized thrombolysis trials. That was a way that we were treating the thrombus in the coronary artery back in the early 2000s. There were a whole host of randomized thrombolysis trials, and before and after the adjustment for age and according to age. And if you went back and looked carefully at those trials, you can see that the relative risk to women as opposed to men, increased risk in women is shown as a shift of that red diamond over there on the right, according to age. You can see that women were even showing way back in the early 2000s, a very significant increased risk. And it was worse actually in younger women than it was in older women. So certainly this issue of the bad results in women has certainly been highlighted by this information that was in the 2016 report. And then there's been a meta-analysis since then, which was published in 2021, which looked at data published from all over the world. And again, that red diamond there at the right bottom shows data from just North America. And you can see that the odds ratio of mortality of a STEMI for a woman is considerably higher in females than males, about a 1.9 to 1 increased odds ratio in a woman as opposed to male. Now, the issue is, what are the potential sources of this sex difference? Well, we've already talked about the atypical symptoms and the problem of interpretation, and certainly that we think that is leading to a delayed arrival of women at the emergency room. Another point to be made, though, is that the whole incidence of myocardial infarction and its problems is shifted to the right age-wise in women as opposed to men. And the other thing to emphasize that the comorbidities that associate with that myocardial infarction are also worse, though, in women than they are in men, particularly diabetes and hypertension. One of the other points to be made is that we think in women, a lot of them actually dissolve their clot, break up the clot, and actually the clot then goes peripherally in the artery and obstructs the small vasculature, so that entity which the previous speaker talked to you about of microvascular obstruction is possibly just a fractionation of the bigger clot and something that we're encountering later. And then the other point to be made is that the delayed time from the symptom onset to the treatment may partially relate to the fact that women frequently are in a rural or non-business environment, therefore less close to a hospital than a male might be. But that's just speculation. In any case, there is hope on the horizon, and I'm going to go past these slides very quickly to show you that at the Cleveland Clinic, published in 2018, they established a so-called guideline directed way of treating women as opposed to men, and tried to make it more equivalent to the treatment of men in the emergency room. And they published this, and they showed that with concerted effort on the part of your protocol, once the woman reaches the ER, you can literally reduce a lot of the problems that you might normally see due to the lateness of the arrival of the woman or the other problems that we've referred to. And so you can see here that the blue bars there refer to adverse outcomes, I should say, in where men fare better than women by a certain percentage, a percentage as high as 10%. You can see that that is all reduced, the red bars, in a different era. You emphasize the new protocol of treating women with greater attention and with greater observance of their vulnerability as compared to men. And one point I want to show here is that if you look at their 30-day mortality using the so-called new protocol at the Cleveland Clinic, they were able to show that out to at least 20 days here, the mortality of women versus men, as shown on the right-hand graph, was approximately equivalent to men. And then one other point I want to make is probably none of this is going to be changed until there's some change in the cultural bias about how we examine women. This obviously exaggerates it. The right side shows a Victorian cartoon of a physician looking at a woman who is fully dressed and multiple layers of clothes, and pretty hard to tell what's going on with her, even though you might use a magnifying glass. And whereas on the left is the more modern treatment of a male in the American emergency room. You can see we slap the electrodes on him, on his bare skin, all over the place, no time. And there's obviously going to have to be some change in the way we treat that modesty issue of women versus men in order to fully probably eradicate some of these differences of men and women. I think I'll stop there.
Thank you so much, Dr. Peterson. In the interest of time, I think we'll move on to the next speaker, and we'll take questions at the lunch hour.